Your moderator is North Idaho College political scientist Tony Stewart.
Good evening, ladies and gentlemen. On behalf of our panel, it is a special privilege this evening to welcome you to the 207th taping of the North Idaho College Public Forum. Also on behalf of the panel, it is a very special privilege to welcome to the program Dr. David Brubachen from Madison, Wisconsin. As to background, Dr. Brubachen was educated at the University of North Dakota, receiving a Bachelor of Arts degree in the field of psychology. Upon completion of that degree, he attended Washington State University, receiving a master's degree in that same field, and then in 1972 received the PhD degree in the field of clinical psychology. At the present time, Dr. Brubachen is the acting director of the Child Adolescence Programs and the director of the Project for Psychotic and Neurological Impaired Children at Mendota Mental Health Institute in Madison, Wisconsin. In addition to that responsibility, he is also a consultant for the International Office of the American Federation of State, County, and Municipal Employees. He further serves as a consultant for the Minnesota Department of Public Welfare. Dr. Brubachen is in the Northwest visiting and has consented very generously to appear on our program and discuss the overall topic of mental illness, and particularly to emphasize those projects in which he is involved at this time. Dr. Brubachen, it's a pleasure having you on our program.
Thank you.
Also, it gives me pleasure to welcome as a visiting panel member to our program, to my left, Ms. Peggy Fedge. As to background, she holds a Bachelor of Arts degree from the University of North Dakota. She holds 2 master's degrees from Washington State University, one being in the field of foreign languages and the second in the field of counseling. At the present time, she holds the position as a counselor within the academic field of North Idaho College. Welcome to our program.
Thank you, Tony.
Also back, one of our regular panel members, it gives me pleasure to introduce Ms. Janelle Burke. Janelle Burke holds a bachelor's degree from the College of Idaho and a master's degree from Indiana University in the field of education. She has served as Dean of Women for 5 years at Idaho State University before moving to North Idaho. Welcome once again.
It's a pleasure to be here, Tony.
We'll proceed to questions at once, and the first series of questions from Peggy Fedge.
Welcome to Idaho, Dr. Brubachen. My first question, now that you're in Idaho, we do things differently here, I'm sure, than you do in Wisconsin. And could you please tell us a little bit about the mental health system in Wisconsin?
I think I probably need about 4 hours. Actually, the way the system is set up in Wisconsin, we have 2 mental health institutes that serve as backup program facilities for the rest of the state. The mental health services are fairly decentralized. I'm not certain how they are here in Idaho. But we really have no large state mental hospitals. The county systems are responsible at the community level to take care of 90% of the mental health needs and are responsible for developing programming for children through the aged geriatric person. There are 2 mental health institutes in the state which used to be, formerly were state mental hospitals. I believe 20 years ago they probably had populations of around 1,000 patients at a time in each of these facilities. Right now, one of the facilities has, I believe, 230 patients, and the other one has 200 patients. And for a state of 4.5 million, that's not too many people in a mental hospital. The county systems do, however, run, along with their regular county hospitals, a section, most of them run sections which are oriented towards taking care of mental patients, or patients in needs of a psychological area. The legislation has changed significantly in the last year, so that we now have what are called, our mental health law is called Chapter 51, and I suspect you have a mental health law in Idaho and it has a different title. But Chapter 51 essentially has broken responsibilities into several areas. One is alcohol and drug abuse, and one is developmental disabilities, and the other is mental health. And the 5142 board, which each county is required to have, focuses on mental health, and the 51437 board focuses on developmental disabilities, which is now a lot broader than mental retardation, which is what we normally associate with developmental disabilities. These county boards in rural areas where there may not be a large population can be a unified board. So you can have one board that has responsibility for both alcohol and drug abuse, mental health, and the developmental disabilities area. I don't know if that gives you any, a broad perspective of the system, but these systems then draw upon the two state mental health institutes they provide the backup and resources. They're the agency in the state that's responsible for training and also treating the most difficult patients, those that cannot be treated locally at this time. Their obligation is to facilitate the development of programming in the community so that at some point they should put themselves out of business. In fact, community resources are developed and continue to develop at the rate that they are developing.
Janelle Berg.
Dr. Brubacken, we've talked just a little bit about the state system as opposed to ours. Now can you tell us a little bit about exactly what you are doing in your state, and as the director, what you do?
My primary experience in the 5 years that I've been there has been developing a research project for psychotic and neurologically impaired children, which includes children who we would label autistic, childhood schizophrenic, childhood psychosis, and neurologically impaired children, children who may have behavior problems and also have seizure disorder, or aphasic children who tend to maybe understand what you say but do not have the communication skills to be able to respond. They may not either understand but can express, or they can express but can't understand. And so the kind of children I've worked with have been a small, select group of children that are really quite unique and not able to be quite adequately programmed at the point that they come in the community system. Part of our responsibility then is to develop the community system to be able to integrate the children back into the community.
I see. This was
after working with us.
This was the purpose of your research then?
Right.
Was to develop a program to work them back into the community.
Mm-hmm.
Now, as a mother of two preschool children, I'm naturally very much aware of how children behave and how not only my own children behave, but how they interact with other children, their friends, and so forth. And I wonder if you could tell us, one of the natural parental things is to want to be perfect. What are the causes of childhood mental illness? And can you tell us something about some of the causes?
Yeah, I guess that again
how do they develop? That's a very large subject. I know. It's a difficult
answer, but let me say that it may be caused. There may be different reasons for the causation, and with the psychotic kinds of children and the autistic-like children that I discussed, would it help if I described what those kinds of kids are like? Autistic-like children. We have in this country the National Society for Autistic Children, which originally was organized by a group of parents and professionals to really help develop programming for a kind of child that's not very common. The frequency is quoted as being anywhere from 2 to 4 children that are like this out of a population of 10,000 children. If you get real liberal about your definition and include anything that's really autistic-like, you might get 20 children out of 10,000 that really have the kinds of behaviors that require very, very special training and special attention. These children lack communication skills primarily, and as a consequence of their lacking communication skills, frequently have behavior problems as well. In other words, they may have temper tantrums, they're not able to express their needs frequently with language, or if they do have language, they may simply be echolalic. They may just repeat back to you what you said. Or they may be perseverative, which means that they say the same thing over and over and over and over again. And having had normal children, you probably realize that normal children do that also. Probably the way that these children differ is that they tend not to outgrow that stage unless they're involved in an extensive therapeutic program. In addition, many of these kinds of children have bizarre mannerisms or stereotypic behavior. And this is common amongst quite profoundly retarded children as well as with autistic psychotic children who may be quite bright. They may be also retarded and psychotic, so we have to be real careful about labeling. And one of the problems with the way everything is set up now is you're supposed to be one thing or the other, and what happens when you're a little bit of each? That's real difficult. So you might see these children making repetitive sounds, or they might be bizarring, one of the frequent ones being flapping hands and making strange noises, bizarre noises, cupping the ears because it makes a different kind of stimulation. We're not really sure why the children do all these kinds of things, but these are common characteristics. At the same time, they may completely lack sensitivity to pain, so that if you pinch the child or when they go to the doctor to get a shot, there's just no reaction at all. There's no reaction to pain. Or there might be extreme sensitivity to pain. The children may be very, very hyperactive, literally climbing the drapes, or they may be very passive, or at times very hyperactive and then very passive. This is very confusing to parents who feel they either have a hyperactive child or a good child, or they define their children in a certain kind of stable pattern. So the children also tend to be very withdrawn. They tend to seek adult attention more likely than other child attention. They tend not to have interaction skills. They don't play well with other children, and it's something you need to teach them. As well, they don't know how to play. So if you give them toys, they may well just rattle them or throw them or eat them. They are intrigued by strange noises and sounds and may get into water rushing and flushing toilets repetitively because it makes such a neat sound. And again, this is something that normal children will do also. I guess what we're talking about is the degree by which these children are frequently obsessed with such activity.
This is very interesting. Can you describe maybe another area of mental illness among children? One of the other areas?
Well, for instance, we may also have, I guess I should comment that the parents of children like this frequently do run into problems realizing their child's different, aren't really sure why they're different, what's causing them to be different. Neighbors kind of complaining because their children are into things they shouldn't be into, needing a lot of supervision. Then that's one type of child that I've worked with, and primarily I've worked with the psychotic children. Additionally, within the programming that I have responsibilities for, we have other children who may come in because of more parent-child interaction problems where the families may not be very harmonious in their own interactions, and as a consequence, the child acts out to get attention. And we have another program for children like that, a children's treatment unit, which focuses more on the kind of child where he may be perfectly normal intelligence, but hasn't really gotten the kind of social support system from his family or from the community, so he's had to act out and do things like burn Grandpa's barn down, and we have an emergency admission.
When you're talking about children, what age limits do you put on them?
We think of our children in Wisconsin as being 3-year-olds to 12-year-olds, and the adolescents then are 13 to 18.
Do you see many cases of schizophrenia at this age?
Well, we probably see more cases of schizophrenic children because we are a mental health institute and we tend to get the children that aren't treated locally. So yes, we do have schizophrenic children. Mm-hmm. And we see more of those than we're likely to see a normal child who has acting out problems.
Is there any projection about how many per thousand?
The range again it's a function of definition, and it's not a common disorder. And the people who do the diagnosis, I tend not to be into diagnosis myself. I'm not really concerned whether the child is autistic or psychotic or neurologically impaired or schizophrenic or symbiotic psychosis. While I think there's some validity in labels, I think we have to be cautious about their use. So my concern is if a child has a problem, what do we do for it, rather than labeling, and because of that, sometimes our statistics aren't very accurate, depending on what our focus is.
Can you describe some neurological symptoms, symptoms of a neurologically impaired child?
Well, many of the neurologically impaired children, of course, have seizure disorder, and so they're likely, some of the children have learned that if, for instance, I fake a disorder, if I fake a seizure, I'll be able to get by with something, or I'll get out of school, or I'll get out of this or that. And so some of the children we have are children who really are who are neurologically impaired, have seizure disorder, and have learned that behaviorally they can get some mileage off this, and what we have to do is kind of try and discriminate at what point they're faking a seizure, at what point they're having a real one, and work with the behaviors that are involved. They're quite challenging and fun children. Also, we have neurologically impaired children, and it may not necessarily relate to seizure disorder, where there's some evidence from a pediatric neurologist that there is some kind of misfunctioning neurologically. And so the child might be hypotonic and might not have complete control over muscles even. And so it's not always psychological, sometimes it's physical.
Peggy,
Okay, I'm going to get back to one of Janelle's questions. What causes a lot of these disorders in children? You hear so many things about the cold mother, or, it's all mom's fault, a cold family. Would you like to comment on that?
Yeah, I really would like to comment on that. My own experience with working with families has been that they're typically not cold mothers, and it's not necessarily a cold family. Now, again, I'm talking about the autistic-like child. For years, all the professionals in the field who did statistics in the area, and much of this was originated at Johns Hopkins University years ago. And to our advantage, they brought a focus on autistic children and their need. They're a very challenging kind of child. They're intriguing. They're very intelligent in some ways and act very retarded in other ways. And so you're always intrigued by the fact, how can they know so much about this and act like they don't have skills in other areas? So at Johns Hopkins University 40 years ago or 35 years ago, when these children were first being looked at, first being brought into clinics, child guidance clinics and things, you can realize who goes to Johns Hopkins 30 years ago. It certainly wasn't the average person on the street. So typically well-to-do, wealthy families went to Johns Hopkins to see Leo Kanner about their autistic-like child. And of course, he, from his experience with these kinds of children, since he only saw the children that came in like that, he thought that they came from very well-to-do families, and that they were families who were very professionally oriented, and therefore somehow out of this, some of the early professionals developed what we call the cold mother syndrome as their way of describing what caused the kids to be the way they were, from a very old psychoanalytic approach, which most people tend not to maintain nowadays. They looked at autistic children as having experienced rejection very early and felt that it was important to separate the child from the family, that it was really impossible for the child to kind of be rehabilitated in the context of the family. And so several schools in this country were set up, and one I'm sure that many people are familiar with is Bruno Bettelheim's in Chicago, and he's written the book The Empty Fortress, describing work with autistic children. And while the National Society for Autistic Children is always involved in a negative way with Bruno Bettelheim because they disagree with his orientation, I feel he's really contributed in the sense that he really brought a focus to the needs for autistic children. He was one of the first people to really try and develop an intervention. And from his perspective and from his analytic perspective, his particular intervention made sense. What we know now is that while some people still hold on to that kind of orientation, we do have a lot of people doing research in North Carolina and California and ourselves and in Indiana, around the country, where they're clearly working with families and training families to manage the children. So it's not very few of the contemporary people who are publishing in the area and doing research in the area would say that there's a cold mother syndrome operating. Unfortunately, because so many people in the medical profession were trained from an analytic perspective, even today, as a parent, if you had a child with difficulty and you thought, oh boy, I think he may have whatever this is, and you went into a pediatrician, you may well get the same story, that you better see a psychiatrist and call a family in for very in-depth counseling and therapy, when in fact the family may not need that. They could also need that. And so we need to be careful, not exclude. Some families do need therapy who are parents of autistic children. So do many families on the street. And so I think we need to be careful and not assume that because a family has an autistic child, that there's something wrong with their interaction style or their attitude towards their child.
Janelle Burke.
It's very interesting to observe multiple children within a family and see the difference in behavior from one to another. So would you say that sometimes the cause might be organic rather than the result of the environment?
Yeah, I'm sorry I didn't answer the question before on causation, and I appreciate you bringing it up. As a matter of fact, there are a lot of people who do feel it's organic for autistic and psychotic children, that especially autistic children, there is a strong feeling that child may be born that way. And while we frequently don't see the symptoms until possibly around 2 years, much of that's due to the fact that the pediatrician is supporting the family and saying, well, the child will probably outgrow that. I mean, everybody bangs their head against a crib, and some children do it till they're 3 and don't really get anxious at this point about that. But in fact, some autistic children are self-destructive and begin that at a very early age. The causation, some people feel it's clearly biochemical, and some people feel it's neurological, and some people feel it's your metabolism and it's your diet, and some people feel it's the way the family interacts with the child, and we really don't know. But I guess most of the people in the field right now do feel that it probably is organic.
About what is the earliest age that such a mental illness can be diagnosed in children? I noticed you said 2 just a few minutes ago.
Yeah, it's rarely diagnosed prior to 18 months. People might notice differentnesses. An infant, for instance, frequently autistic children are referred to as perfect babies. They're quiet, good, and they frequently don't like being held, but then you don't have them screaming and hollering and the things that infants do. So the parents are kind of relieved, and all of a sudden, but at the same time, there's a feeling on the part of the mother who may be nursing the child that there's a rejection there, and that makes it difficult for the parent, and the mother has to deal with her feelings about this rejection. Not frequently, it's covered up, and one doesn't admit it till later on, and then retrospectively, one says, "Gee, now that I think about it, I really, my child really never liked being held, and as long as I set him down, he was perfect. If I held him, he screamed and hollered and cried, so I set him down, he was a good kid." But at 2, when he's continuing to want to be left alone and not wanting to be engaged in stimulating interactions, and is afraid of new things, which is one of the ways all children are afraid of new things. But autistic children tend to be very, very fearful of novel and different items in their environment, and will really react frequently with temper tantrums.
Now, I would understand from what you have said before that you have some rather definite feelings about how the treatment should be carried on, and that is the area of research that you have been exploring. So I wonder if you might say some of the ways that you think that they should be treated, or what approaches we might take.
Yeah, well, I will begin with my first preference is that the children be treated in the community, as close to home as possible. And it would be really nice if we had in this country, which we don't have, a situation that every child could be getting a real adequate intervention system within 50 miles of their home. And while our federal government and many of our states are oriented philosophically to that, it is not practical at this time. So we have to develop models based on the community needs that allow for maximum intervention for these kinds of children. And the program we developed in Wisconsin, Wisconsin's a fairly rural state. Population-wise, it's about as large as Washington State. It's large. The population center seems to be in the southeastern part, Milwaukee, Madison, Racine, Kenosha, those areas. So the focus in the state is down in this area, but yet we have all this geographic area to serve, and it's impossible to develop a model that would provide the kind of intervention we want in all of the areas. So essentially we've had to compromise in Wisconsin. In states that are more populous, they shouldn't need this kind of compromise. Therefore, we have the 2 mental health institutes, and both of the mental health institutes do have programs for autistic, psychotic, neurologically impaired children. If it's to the degree that they're very unmanageable and difficult to educate in the home community, the children would be referred to one of these 2 programs in the state, or Milwaukee County also has a program. again, I believe the children should be kept out of the home for as short a period of time as possible, and that we really need to continue to keep the parents involved actively during the whole process of treatment. So the particular model that we've developed, even if the child comes from very, very far away, and I'm not sure if you know where Superior is, but it's way up by Duluth, Minnesota, and it's a long ways from Madison, but that's in our area. We have responsibility to service children in that area. And what we have done is we have arranged with all the complicated agencies that are involved in the delivery of health services. We try to involve as many as possible in an integrated effort to provide the best treatment for that particular child. So we've had children from Superior who've been in our program who are flown home on weekends to be involved with their family and to work with the family, and so that the family can practice the kind of intervention we're using. So they learn our intervention and can practice it on weekends. So the child's getting remediated in an inpatient treatment program, spends weekends at home, every weekend if possible, but if you're from a great distance, that's impossible, and an intensive training of the family and community people that are involved.
I would presume then that you are separating out the family where the child is mistreated, and that his reaction might be to his mistreatment, from the family who has a normal family habit. In other words, you don't have children who are being abused.
No,
in your program.
They're in a
you would
different
separate
program.
those out.
Although sometimes a child that's been abused may exhibit the similar kinds of behaviors. We do treat children who have suffered from what we call social isolation, deprivation. Children who we have taken children to our program who've been 6 years old and are still on a bottle and do not eat solid foods, who left 6 to 9 months later talking and having social interaction experiences, but still different, not having real normal interactions like regular children would. But we've taught them a lot of skills in a very short period of time, and those kinds of kids may exhibit some of the same kind of bizarre speech patterns and some of the stereotypic behavior that you would see in autistic-like kids.
Do you work with the family in that situation also?
We prefer to work with a foster family rather than a natural family. Frequently, if a child's brought to us in that kind of condition, it's because the child is being taken out of the home and there's been this discovery. That's not common at all. It's very uncommon to come across children like that, and I believe in my 5 years there we've only treated 2 children like that, which is fortunate. But it's integrated very much with the court system, and we go along with what the court decides. And we have input with the courts. So they listen to us, they ask us for our opinions, but they make the decisions, and we do not deny a child treatment because the courts made the decision that the child can be returned to his natural home.
Earlier you said intervention and intervention treatment. I wonder if you could explain what kinds of intervention you're talking about.
Well, that's another 2 hours. No, I'll try and do it very briefly. In the particular programs that we've developed, our intervention is primarily teaching the children a lot of interaction skills. And so again, for the autistic-like child who has no eye contact, is frequently withdrawn, may well be standing in the corner into sensory modalities, maybe feeling the walls, and not excited about people. What we have to do with them is we have to really impose ourselves on the child, and we have to kind of intrigue the child so that they become more interested in us than they are in themselves or their internal sensory modality interests. So that requires a rather loose staff with a fairly consistent program. So for instance, we have a child who won't put puzzles together. Well, if this child's going to go back to the community and is going to be in a public school system, and the public school system in Wisconsin is required to provide education for any child with special learning problems between the ages of 3 and 21. So at the age of 3, we're in. We may educate the child in our own school within our program, but when they return to the community, the school system has to provide an education for them. So we want them to be able to sit, for instance. Now, we've had children that can't sit still for more than 15 seconds. Well, you can imagine in the public school system a child sitting still for 15 seconds, what that's going to do to a teacher who may have 12 children in her class, herself, and an aide. You can't have a child just running up and swinging and pulling on this thing. So one of the things we have to focus on is teaching the child to sit. So we've had people visit the program and they say, why is that child sitting there? Well, it's part of what we're trying to do is develop that child's ability to sit without an adult having to interact for a period of time. At the same time, we want them to learn to interact appropriately, and we have a very extensive program for teaching that. But for instance, if the child won't play with puzzles, and he won't hold the pieces and he throws them or chews them or eats them, what are we going to do? We have to teach him to occupy himself in a constructive way, rather than flapping his hand and making noises, which we would prefer he be engaged in some kind of appropriate activity. So our intervention is primarily based on how do we teach these children appropriate activity to occupy themselves and hope that they'll actually get excited about it. So they'll get excited enough that it becomes self-reinforcing and the learning process itself becomes exciting for the child and they're looking for new stimulation. That's our goal. It's a very long process getting a child to that point, and we frequently have to start with things like teaching the child to look at you when you call his name. We might give 200 trials a day where we call a child's name and ask him to look at us so that he's learning to attend. Prior to children coming in, it's not uncommon to walk around the home and someone will call a child's name and the child's like he's deaf. As a matter of fact, frequently parents and professionals feel that these children are deaf when they're referred to us. In fact, they're autistic, they're just tuning out their environment.
I could talk to you all hour, I know. I just have to ask one more question. As a parent, I certainly would like to know about temper tantrums and what you do, intervention in temper tantrums.
Well, we use a procedure for temper tantrums. There are a variety of things you can use for temper tantrums, but in terms of our consistency, and we have 38 staff that work with 16 inpatient children, it's important that we intervene consistently when a child has a temper tantrum or is aggressive or is flapping his arms or doesn't listen to you when you ask him to do something. So we use a procedure which we call timeout. Now, timeout can be, we probably all use timeouts. When you were a child, your dad or mother probably told you to go to your room when you had misbehaved. And it's a similar concept, although we, for our children who tend to have short attention spans, don't use extended periods of time. And what we do is we teach the children when they're inappropriate to take a timeout sitting on the floor. They're expected to sit on the floor and cross their legs and put their hands on their knees. Now, the reason we teach them to do that is so that if they've got their hands on their knees, they can't be flapping, which is very stimulating and exciting to the child. And we want the timeout to be a real neutral period of time, that they can't be having a lot of fun or they won't want to engage in the activities we're doing. At the same time that a child's taking a timeout, we're making certain that we're having a good time doing whatever he's missing so that the child wants to get back into the activity. And for very, very autistic withdrawn children, it's a very difficult procedure and it takes a long time. And also, it's much more difficult to intervene with a 10-year-old than a 5-year-old. So I guess our approach to treating temper tantrums is it's essentially the same thing as telling a child he has to go to his room. It's for a very short period of time, 30 seconds to a minute, that the child's expected to stay on the floor, keep a spot on the floor. If he fails that, we may take him to a timeout room. And sometimes we'll have a child just sit in the chair in the corner. It really depends on what the child's capable of doing that we use. But we let them know that that is unacceptable. And with the brighter children we work with, they're expected to bring themselves under control, to learn to manage their own behavior. And so we just define temper tantrums as unacceptable. I don't know if I answered your question.
Yes, you did.
Dr. Brubachen, in your program, it appears to me that you have children of very different behavior patterns, and that there must be some of them that are rather difficult to manage in a physical way. How do you handle the children that are most violent? Do you have what kind of policy do you have for your staff in relation to any type of physical force that might be used?
All right, we do have a policy that we do not use medications to control children when they're acting out. In rare circumstances, however, the psychiatrist can order the nurse to administer medications for adolescents and some of the children. But, for instance, with the population that I worked with, we do not use any medications in the treatment process. Our feeling and the reason we do that is most of the children, by the time they come to our program, the doctors have pretty well tried every medication under the sun, and what it tends to do is it may dope the child up so he's unable to be aggressive. Sometimes we think aggression is an appropriate expression for a child that's been very, very withdrawn, and who may be self-destructive. For instance, a child who gets frustrated and hits himself or bites himself. We're actually delighted if he tries to hit somebody else. This is an indication that he's learning to express his anger outwardly rather than internally. Now, at that point that it becomes dangerous for somebody else, we have to teach him to control that, and we have to manage and monitor that also. But it may not always be bad if a child learns to strike out. Depends on the kind of child and the kind of problem. Now, if we have just an extremely acting out child who's very, very aggressive and hitting people and things all the time, we would more likely use a timeout procedure, which would be an empty room, and he would have to go in the room for 5 minutes to bring himself under control, than use medications or any form of restraint. I know it's frequently common in many institutions to use restraint and medications, and I'm very happy that we've never used restraint as long as I've been there, and medications have been used, but very, very rarely.
Another question deals with the hyperactive child, and certainly some of the ones you've been describing are hyperactive, but let's be more specific. We interviewed a professor from Eastern Washington State College who is certainly an expert in the hyperactive child, and he pointed out in this program that there certainly are many philosophies on what causes a child to be hyperactive and whether it is a physical problem or whether it is really a mental problem. And I would like to get your view on how you perceive the hyperactive child, what causes it, and secondly, what kind of treatment do you use?
Well, hyperactivity is almost a low priority given the kind of severe disturbance that I frequently deal with, so I'm never very concerned if a child's hyperactive. We work very extensively on teaching the child to manage himself and bring himself under control. Now, medications are used, such as Ritalin, for controlling hyperactivity. On one of our programs, the Children's Treatment Unit, with hyperactive children, we do use medications. But my concern about that is, and of course I'm not a medical doctor, so I have a different orientation, is that we do have some evidence to indicate that when children are on medications, they do not learn as well academically. And if in fact they're not learning academically as quickly as they could, we're not really taking advantage of our opportunity to teach the child something appropriate rather than flapping. I mean, we can teach the child to engage in appropriate activity to burn up his energy. The other concern I have is that the word hyperactivity is used so broadly that I think we've made some errors. I believe it was 2 years ago there was a study that indicated something like 30% of the children, 20 to 30%, I'm not sure of the statistics, in the San Francisco public school system were on medications for hyperactivity. I have a very hard time believing there are that many hyperactive children. I think what that really says is that we have possibly parents and educators who are really not willing to deal with the fact that the child may be bored and is looking for stimulation. And I think the challenge is on us to come up with ways of stimulating the child appropriately rather than medicating them, calming them down so we can control our own nerves.
Thank you. Peggy Fedge.
Okay, I have really a three-part question. When a child leaves your program, how long has he been at your institution? Then when he gets into the community, what happens to him? And how normal is this child after he's finished your program?
That's a very good question. The length of stay typically for our children ranges from 6 months to 12 months. It's very, very rare that a child would stay longer than 12 months. And the average length of stay is 9 months. Most children are there 8.7 to be exact. But the length of treatment, we are staffed very intensively, so we can provide very immediate intervention, and we can work with the families consistently over this whole period so that at the time the child leaves the family, when the child goes home on weekends, that child is behaving as well in the home as he is in our program. That indicates to us that the child really does not need our program any longer. Additionally, we train the community teachers where the child's being returned to. We have them come into our facility and work with us for 2 full days. And it's not like they come in and sit down and watch us work with a child. It's very, very intensive, so that we're using videotapes and role-playing, and we're showing them exactly what the child was like before he came in with our videotapes. And we're acting probably I really enjoy this part myself. We may role play the part, so I may take the part of the child and act out, and I'm very good at that. And the teacher has to learn to control me. And so she really learns how difficult the child was to manage, and she's quite motivated after seeing the videotapes of the child to learn the programs and learn the management systems we use. So when she leaves, she may have a book about this thick of programs that are specifically designed for the child. The average child that goes through our program has been on about 250 different management orders, which are treatment programs that we've used to deal with behaviors that the child's exhibited that we feel need to be controlled or expanded. Many of those programs are to teach skills, like to teach dressing, to teach language, and they're very, very positive programs, as well as some of the programs which we would consider negative programs, because we're expecting the child to manage certain behaviors that interfere with his ability to learn. You cannot have the child walking all over the room and learning rebus reading at the same time. He has to learn to sit, and we have to teach those prerequisite skills. So the length of stay is about 9 months. The community teachers are trained. We may train someone at the mental health center. We may train somebody in the public school system. We always train someone in the public school system, and hope that they can provide the support for the family since the family's been trained. It's really difficult for a family of a child like this. They realize that they have the only child like this in the county. I mean, if you're from Wood County, Wisconsin, the statistics I quoted would indicate there's only one in the county. And families are very alone, because they may bump into other parents who have children with handicaps and disabilities, but they rarely run into one that's quite as bizarre as theirs. And so they're feeling kind of alone and isolated. And one of the things we want the families to develop is an ability to call on the community resources, the mental health center, the public school system, and keep open communications, and also to be very open in communications with other families who have disability children. We just had a reunion at our program where we invited all the families and children we've worked with to come back after 5 years, and it was a very exciting experience for me and for the staff to see the children and families came from hundreds and hundreds of miles away just to see the other families and how's your child doing. And it's like there's an alliance amongst parents of this group, and that's why we have the National Society for Autistic Children. They seem to find a lot of support amongst each other, which we try and facilitate. But hopefully when the child is returned to the community, this community system is designed to meet that child's needs. Now, there's no way that they're going to develop a classroom for autistic children in some of the rural counties when they have one child. So what you have to do is you have to take the most appropriate approximation, and then you train them to meet the special needs of the child within that situation. And we follow up very, very closely when a child's discharged. We spend three of the days in the first week in the classroom with the child, with the new teacher, so that we're helping her adjust all the little things he's going to test out. Because these children are quite bright, even though sometimes they don't act it. They know what's going on. And they may not have eye contact when you ask them to look at you, but they're always looking at you out of the corner of their eyes just to see what you're up to. And I guess we want to make sure that the teacher isn't getting the wool pulled over her eyes. Well, we know the child very well, the family knows the child very well, and sometimes we'll involve the family in working in the classroom as well. It may require our involving the Department of Public Instruction and getting extra support, like an extra aide for the classroom. But with all that effort, we're very, very pleased because our results are indicating the children are continuing to live in the community, are not only being maintained, but they're improving after discharge from our program. And we're very excited about that. We were concerned that the intensity of our program was such that it couldn't be duplicated at the community level. And we're finding that while the exact program cannot be duplicated, the approximations are working very well at maintaining the child quite well.
When these children are back in their hometowns and in their classrooms, are they in the classrooms with the other children their own age? Are they interacting with children who are their own age in an almost normal way? What are these children like, let's say 5 years after your program? Well,
Peggy, it ranges from child to child. And it's one of the things I've learned is it's very, very hard to predict. I used to have different theories about which children were going to do the best and which ones weren't. And I usually thought, well, the more retarded they appear, they won't do as well. And I found that that's simply not true. I mean, we've taken children in who couldn't couldn't feed themselves, were not toilet trained, couldn't dress themselves, and in 9 months have left with all of those skills and are talking in blue streak and talking in full sentences. And I'd have never predicted that if you looked at the child that came in the door. And we've had other children come in who are already talking and they're echolalic, and we think, oh good, they're already at that stage. They'll just buzz right through this program and we'll treat them in no time and they'll be out. And in fact, the progress has been very slow. So there's a lot of individual differences for the children in how they progress and how they move. Some of them, we have had some of our graduates go into normal classrooms. They've left our program, gone into special ed classrooms, and now, like 2 or 3 years later, are now in normal classrooms. But those are very, very rare. That's clearly the exception rather than the rule. But it's very exciting when it happens. And it motivates the staff so that any child that comes in, they think, has that potential, and it really creates a very positive and constructive attitude amongst the staff. But the children, I guess we probably should talk about the normalization concept, and one of our goals is to normalize. And when we're teaching a child to eat, we don't set them down at a table in the middle of the day and teach them to eat. We teach them to eat when it's time to eat, at breakfast, and at noon lunch, and at supper time, and at snack time. And so they're learning the behaviors at the appropriate time of the day. And we want them to be as normal as possible. It's when we teach eye contact and we call a child's name and we ask them to look at us, that's not normal. I mean, I don't know if you ask your preschool children to do that or not, but I bet frequently you call their name and talk to them with their head facing the wall, but they might do what you ask them to do. In our case, we're not sure they got the message unless they're looking at us who asked them to look at us. But we want to shape that out so that we're having more normal interaction style too. So we go to a language stimulation model. And so we'll call the child's name and say, gee, that's really a pretty yellow blouse you have on today, Shelley. Give them a little stimulation, they smile, and they get more excited. We try and teach them to respond more normally. And eventually we get to the point where we would ask them a question, we'd call their name, and we'd say, Shelley, where are you going? And she'll say, well, I'm going to school. Something that's normal. So we really try and take programs which are very concrete and deal with very specific behaviors, and we try and normalize them so that when the child does leave, the child looks like a normal child. And it was very fun when our children came back for our 5-year reunion to see that many of them, when they walked in the door, you would never know which child had been in the program and amongst their brothers and sisters and which ones hadn't. And that's really very fun because they had learned many adaptive, normalized skills.
Janelle Berg.
We take regular precautions with our child's physical health. What kinds of preventions can we exercise with our child's mental health? For those of us who have normal children and for those who do not, where can we go for help, and what kind of precautions can we take?
I guess the answer to that is good parenting. Now, if you there are a lot of courses being offered in good parenting. I have no idea whether they're any good or not, but I think probably some of the essential things are teaching communication skills, honest communication skills with children, especially with normal children, that they learn sensitivity, sensitivity to other children, sensitivity to parents and their needs, that parents get upset too, and that the interaction style between parents be positive. That children, I believe our culture has been so, I'll make my cultural statement now on the Protestant ethic, but I believe that we've been so trained to think that children should behave that we forget to tell children when they behave that we like it. And that's something that any parent with a normal child or a child with a disability should remember. It's really important. I like people to tell me when I do a good job. And I'm an adult, and as a child, I very much needed that. And I got that, but not enough. I would like to have been told more frequently that I'd done a good job on something. But we kind of assume, since a child's normal, and he's bright, and he's doing all these things in school, that that's what we expect. Our expectation is that he do that, and we shouldn't have to tell him he did a good job. I mean, he should just know that he did a good job. Well, internal motivation is one thing, and we need that too. But I think as parents, we ought to make a much stronger emphasis on telling children we like what they do when they do things we like. And when they do things we don't like, we ought to inform them that we prefer they not do that, and then as soon as they do something right, say, no, that's more like it. That makes me feel much better about you.
Do you think that our current trends toward unisex, in other words, we dress little boys and little girls alike, they wear their hair alike and so forth, they share certain clothes, and then the blurring of traditional sex roles in the home, do you think this is confusing to children?
Well, I think it's, I guess I don't feel that the sex roles are really blurred that much, even by that process, because our culture is still at a point where they don't accept the unisex concept. And I think that's very healthy for children to be brought up to look at people as individuals rather than, it's very important that as a boy, you be out in the field or out in the woods, or that you be playing football and basketball. In fact, I think it's exciting that women's athletics has developed to the point it has, because it's saying to little girls that it's okay to go play in basketball or to go into track. And I think culturally we are getting away from it, but I don't believe that, I can only see it as a positive effect on child rearing and child development.
Do you know about places that we could go within our area to receive help of the nature you're talking about with children who are not normal?
Yeah, I'm not real familiar with the system in Idaho, but several people who've trained at our program at the Mendota Mental Health Institute have taken jobs in this area and are working, for instance, with the Child Adult Development Center here in Coeur d'Alene and at Sandpoint. I know 2 of the individuals there were on our program dealing with the psychotic children, and I know we have a very multidisciplinary concept where we have education, speech pathology, occupational therapy, psychology, psychiatry, a real integration of disciplines in terms of making decisions about children's needs, what areas they ought to be growing and developing in, how we work with families. And I know these individuals have a similar philosophy, and I know they are here in the area and believe very much in these same principles and believe in an integration of disciplines. I think that's probably one of the things that's so important I haven't emphasized, is that as a psychologist, I don't claim to know completely about the treatment of psychotic and autistic children. I'm very delighted that we have professions, many professions that have skills in many areas, and what's been exciting for me is working in an interdisciplinary team, so that I've learned a lot about language development, and I've learned a lot about teaching self-help skills through other disciplines. And I think any system that's presenting services to the community should be multidisciplinary. And I believe that this is the way the programs are developing here, and that's exciting.
Dr. Brubachen, I'm afraid it's time for the political science question, and that is that obviously if all states were to adopt the particular program that you're experiencing in Madison, Wisconsin, it would require a decision of government that certain laws regulate these centers and these institutes, and certainly it takes a staff, and that takes money from the public treasury. What does a program as the one that you have at Madison cost to deal with this child? Suppose you mentioned the fact that about 8.7 months you have a child. What does it cost to keep a child and train them for that period of time?
The cost for a child in our program per day is $102 a day, which is very, very costly. And the actual cost is greater than that, but it's picked up by the state. Now, $102 a day is billed back to the county from which the child has residency and the family lives in. And so I guess I have to say, yes, it is costly. But I think if you wait until the child turns into an adult, and we haven't provided the intervention, what we have is a child we now have a child that can live in the community in 90% of the cases. And they never need residential care. Now I'm making my justification for cost.
Are you indicating, though, that these funds are really paid out of the county treasury rather than the state in Wisconsin?
It's reimbursement, and much of it is federal money.
Oh, federal money as well. Because, for example, in a state such as Idaho or Montana, or even Washington, we have small counties. One county in Idaho has a population of 800 people. And, of course, the county government could not deal with that, although I realize every county would not need such a center as this. And therefore they could pay on a proportionate basis, but you do say that federal funds are involved.
Mm-hmm. The children who enter our programs, almost all of them qualify for medical assistance and Title 19 funding. So the county gets paid from the state and from the federal government, and then they purchase the services from us. And that's essentially the way it works. Now, it's a costly program, and politically, we get called on the line. And I believe what you need to do in developing these kinds of programs, and what we've done, and I believe that's one of the reasons we've succeeded through the budgets with the cuts that have been occurring, especially in the area of children's services, we have good justification for our program. We have results, and we assess them. And any program that we're doing, we ought to have a component in there that assesses its effectiveness. Because for too long, we've assumed that children who are autistic need to be taken away from their parents and placed in institutions. We don't have any real research evidence to support that, and that's been an error. And now we know we have a program that we can work with, that children can stay in their community. If they're not treated early, they're likely to end up in an institution for the mentally ill or the mentally retarded, and the cost there is $60 a day for average treatment. So the cost is much greater because you're talking about a lifetime of expensive cost versus a short period of very expensive cost. And it's still difficult to communicate to legislators the need for this kind of early intervention.
Peggy.
Okay, I have one final question. You spoke earlier that autism could be recognized, I believe you said, at 18 months old, but that your program looks at children starting at 3 or 4 years old. What are you doing or what can be done in the area of early intervention or early diagnosis?
Well, again, since our program is a residential program, although we do provide a lot of consultation and training to prevent children from coming into our facility, we keep probably half of the children referred to us out by going out and training, not feeling they need what we have. Underneath all of this treat stuff, I'm a softie, and I just can't bring little kids into institutions, even for a short period of time. So we will not take children in who are younger than 3 1/2. What we have done instead is we're developing what's called a primary prevention project, which hopes to work. We're just in the process of developing, and it's been implemented. We're working with families, and it's completely oriented to working with infants 0 to 3 years old. And our hope there is that, and it's not a costly program. It's a very reasonable program, and its cost is $5 an hour for services rather than $102 a day. And we're really hoping that the cost to treat one child is so low in that program. We can treat 57 children for what it costs to have one child come into an institution on a residential basis. So we're hoping that if only one child out of 57 doesn't have to be institutionalized at some later point, we've saved money for the taxpayer. Our hope, of course, is that 90% of the children we intervene with will not have to come in, and it's focusing on teaching the parents to deal with their attitudes and feelings about having a child with a disability at a very, very early age, and hopefully develop a very positive attitude, as well as teach them techniques. I mean, here you've got a child who has a disability, and the child's very young, and you know that this is going to be a problem and to some degree a burden for you the rest of the time. We want the parents to feel better. We want them to learn how to utilize community resources and get support from the system. So we do have a program for that now.
With that, Dr. Bruback and I must bring our program to conclusion. The clock has caught us again. I would like to say on behalf of the panel, I'm sure that they have many more questions, and we would like to have pursued questions on your work with county, state, county, and municipal employees, and I would love to deal with questions about state laws on all areas of mental illness, but we must only at this time extend the invitation for you to come back, and we'll pursue these at another program at another time. Again, thank you. Ladies and gentlemen, be with us again next week on Channel 7 at 6 p.m. from Spokane, Washington, when again we'll be interviewing another personality of the United States. And until that time, good evening.
The North Idaho College Public Forum can be seen at this same time each week over this station. The preceding student production was brought to you by videotape recording.